I've been asked today to give a more general talk about the approaches that our research team at Southampton use to develop, test and disseminate our interventions. And I'm not saying that those are the only or the best approaches, but we just wanted to share some of our learnings to see if they help you with your research. And I also just want to acknowledge that I'm here representing a much larger team. So I won't be able to go into too much detail, but I'm more than happy to answer any specific questions in the coffee break or refer you to somebody within our team who can if I can't answer those questions. So I split the talk today into two parts. I'll first describe our general methodological approach to intervention development, which we call the person-based approach. And I'll then introduce the LifeGuide software, which is a specific suite of software tools that we use at Southampton to physically create the interventions that we evaluate. And through each section, I've just picked out a couple of examples of some of the work to just illustrate how these approaches have been used in practice. So I'll start by thinking about the person-based approach. And this is really something that's just evolved out of our own learning process from developing numerous different interventions and conducting lots and lots of qualitative work with our users. And we're now at a point where we've accumulated evidence from RCTs that the interventions we've created are successful in changing behaviour. And so we now feel a bit more confident in sharing what we've learned because we have some evidence that it actually works. And the clue is in the title, in that we're placing the person very much at the centre of what we do, and that's in line with much of what's been talked about already today in terms of user-centred design. So the whole idea is to conduct qualitative research at every single stage of intervention development, right from the initial planning phase through to the evaluation and the trialling and even the implementation phase. We don't just kind of look at the interaction between the person and technology. The idea is to get a very deep understanding of what's going on in the behaviour change process, both before they use the intervention, while they're using the intervention, and after they've used the intervention. And that includes exploring what's going on offline, so how they're taking that advice forward. And as I say, we start with a very bottom-up approach. So before we even design the intervention, we conduct qualitative interviews with our patients to really understand what the key behavioural issues are that they're encountering. So, for example, when we created our weight management intervention, we wanted to know what their prior experiences of weight management had been, what their key barriers and concerns were, what their daily routines looked like, and how they were using that advice in their daily routines. And the idea being that we can then identify the most important behavioural issues to address in the intervention, because we couldn't possibly address everything, and it just helps us to prioritise what we're doing in the intervention. And we accumulate that within what we call guiding principles, which just helps to collate that information and help us to prioritise through the development process when it's very easy to get carried away with the fancy things you can do with technology. So as I say, I've got some examples of how this works, which I can take you through. So this slide here is just to illustrate the kinds of qualitative methods that we're using at each stage. So during the planning phase, we typically use focus groups or interviews. And as I say, that just helps us to uncover what's going on with people's past experiences, behaviour change, and therefore what we might be able to do in the intervention. Once we've got a prototype for the intervention, we typically conduct think alouds. That helps us to understand people's immediate reactions to the intervention. But we also conduct kind of longitudinal retrospective interviews where we send them off for a bit with the intervention. They come back and tell us how they've got on. And that's useful for refining the design and delivery of the intervention, so any particular bugs or usability issues, but also refining the way in which the content of the intervention is communicated. So sometimes there could just be specific words or language or tone used in the intervention that is really being misinterpreted or really off-putting people from the intervention, and at that stage we can change that before it goes to trial. Once we get to the trial and the evaluation phase, we again conduct more interviews with as wide a range of possible users that we can get our hands on. And that has loads of different advantages. So firstly, it can help to contextualise the primary outcome data that we're collecting, so it can help to explain what's going on. It can also help to explain anything unexpected that we weren't expecting to find. And it can also help you to get at what's going on offline, because often we collect lots of data about how someone's using an intervention or not using an intervention, and the qualitative data can help us to understand what's going on after they've looked at your intervention, when they've gone off and they're going about their daily lives. How are they using the advice that we're trying to provide to them? So the example I want to take you through is called Healthy Mind. So this is just one example of an mHealth intervention that we've worked on at Southampton, so I thought it was quite apt for today. And just to give you a bit of context, the idea behind the app is to support healthy stress management. The content itself was adapted from an existing web-based intervention that was developed by other colleagues. And it was created specifically to explore the role of app-based notifications. And in particular, a kind of similar questions to Felix, we were particularly interested in whether it mattered whether we could tailor the timing and delivery of the notifications and how that impacted engagement. So what we did was... Oh, that hasn't coming up. It's not coming up. I'll just explain it to you. So what we did is we had different versions of the app. So some were in an intelligent version of the app where it collected GPS data and data on people's movement levels, and it gradually learned when people were reacting to the notifications and then continued to send the notifications at that time. And then we compared that to a non-intelligent condition where we just sent the notifications out at a set time in the evening, and we wanted to know whether the sensor notifications resulted in better response rates, and we also varied the frequency with which notifications were sent to understand whether it was acceptable to send daily notifications or whether it was more acceptable to send them less frequently. So that's just a summary of what the study was about. This slide's not going to work either, but let's not worry about that. So I just want to explain how we use the person-based approach to create the app. So initially we conducted focus groups with people to explore their prior experiences of using apps and identify the particular challenges that we might be facing in the creation of the Healthy Mind app. And the kinds of things we found out is probably as you'd expect, that people were seeing apps as disposable. They weren't ever expecting to use them for a long period of time, and it was something people download, have a play around with and throw away. So we're facing, particularly if you're trying to answer a very specific experimental question as we were, that we needed to keep them using the app to answer that specific question regardless of any behaviour change associated with that. They're also very sceptical about the use of modern technology, particularly sensor data, which is exactly what we wanted to use in the study. And they were generally not very trusting of how we were using that data or whether or not it was going to be useful, which again could cause them to delete the app. And they were also a bit sceptical about the use of prompts. So they were quite happy in principle to get the prompts, but they were worried that it would feel like their phone was nagging and harassing them or potentially embarrassing them if they're popping up at times when you don't want them to pop up. So again, we had a particular challenge in trying to make the app as rewarding as possible to encourage people to use and respond to it. Once we'd had a prototype of the app, we conducted the think alouds and the semi-structured interviews, and again, we found that there were some tools. So one of the tools in the app suggests that people set aside a time in the day to worry about their problems, which is called worry time, and there's some evidence around that. And we used that phrase, worry time, but what happened was when people were using the app, they felt if they weren't currently worrying about their problems, that the app was basically telling them they needed to worry more, which obviously wasn't what we were trying to encourage, but that was the interpretation it was having. So we had to refine some of the language in the way that tool was introduced. And if we hadn't done that qualitative work, we wouldn't have understood that, and we could have potentially had adverse consequences with people using the app on their own. Finally, once we did an exploratory trial of the app, and essentially what we found was no differences between the kind of sensor-driven prompts and the non-sensor-driven prompts, or in how frequently the prompts were sent. But the qualitative data kind of helped us to contextualise why that might be, and I think probably one of the most important reasons was that users learnt the tools within the app very, very quickly, and what they were telling us was they were still continuing to use the app, but they no longer relied on the technology itself to encourage that. So if we were just looking at the usage data alone, it's kind of disappointing, but actually listening to the qualitative data, it seems that actually it was very quick for them to learn the techniques. And potentially this kind of sensor-driven tailoring is potentially more useful for behaviours that require more sustained engagement or are harder to change over time. So just want to move on to an example of guiding principles, because it's quite an abstract concept, so I thought it'd be useful to give a concrete example. So just to recap, the idea behind this is just to collate the insights that we collect from our qualitative research, to define what the key design objectives are going to be for the intervention. Often, if we don't do this, we find we have too many objectives to address, so this just helps to really narrow down our thinking and ground it in what the people are telling us that they need. And then we move on to identifying key features that could help to address those objectives. So it could be particular behaviour change techniques we need to include, it could be a particular way in which we need to communicate those behaviour change techniques, or it could be particular aspects of the technology or the setting in which we need to deliver that. So these are just the example of the guiding principles we created for Healthy Minds. So based on our focus group data, we knew that we needed to provide a positive, useful and rewarding experience, and that was one of the biggest challenges we had to face. So we set that as one of our objectives. And we thought about some different ways in which we could tackle that. So the first was to provide brief chunks of content. So we knew that typically users engaged for about kind of 3 minutes or less from a previous study we'd done. So we made sure all the content that we developed could be used in that way so it could fit quite nicely into their daily routines. We tried very, very hard to provide a range of different tailored notifications, so we won't keep sending the same things over and over again. We introduced a game-based element where not all the tools were available at the beginning, and the more people used, the more became unlocked. And we allowed as much user control as possible without undermining our kind of experimental design about when the notifications could be received, or basically specifying times when they didn't want to be prompted. And our second design objective was to persuade the users that the app could be trusted, because we knew that people had quite a lot of scepticism around the use of sensors, which is exactly what we wanted to do. So this was primarily not even at the intervention stage, but at the kind of recruitment and consent stage of just being very transparent about what we were doing, how we were using their data, and why that could be useful. But within the tool itself, we made sure we provided very strong scientific rationales for everything we were doing, so we could persuade people that this approach was going to work. So just a quick summary. The idea behind the person-based approach isn't to prescribe a particular way of doing things, but really just to advocate the systematic use of qualitative research right through the development and evaluation process. But that's quite resource intensive, so it's not always possible to fully implement that as you go along. But one thing I would say is we've learned that investing time at the early stages, so during the planning and the development stage, is where it really needs to be, because if you can get it right from the start, that can really optimise the intervention that you then take to trial. And we do use this approach in combination with other kind of systematic and theory-based modelling approaches to intervention planning. So it's not a case that this is an alternative method, but it's just something we do in addition to the kind of typical approaches that you might be used to using. And we do have a couple of papers that explain this approach with more examples in more depth. So if you are particularly interested, you can look those up online. So for the second part of the talk, I just wanted to introduce the specific software tools that we use to support this iterative development process. And these are collectively known as LifeGuide. So as I said, they're a suite of software tools that you can use to create interventions, but once you've created an intervention, you can also modify it, share it with other people, and obviously disseminate it and evaluate it with users. And the reason these tools were developed in the first place was because we were often relying on buying in software development time or computer science time to program these interventions for us on a need-by-need basis. But what that meant was when we were doing our qualitative research and we wanted to make changes to the intervention, we then had to find more money to make those changes, and it significantly slowed down this iterative process and how long it took to do things. So by having the control yourself of being able to do this, it can speed up that cycle. And the idea is that it can be used by anybody, so you don't need to have computer programming experiences to create your own apps or to create your own websites. And it's free to use, and it's also open source, so if you do have access to technical expertise, you could potentially build on the software that's already there if you need it to do something that it doesn't already currently do. So in terms of what tools are available, the original LifeGuide was used to create web-based interventions. So that's been around for quite a few years now, and it's quite a robust piece of software. We've recently developed the LifeGuide Toolbox, so that's LifeGuide for apps, so to help you create your own app-based interventions. That's kind of in beta development at the moment, so it's not widely available as yet, but we do have a developer working on that as we speak, so that should be available quite soon. And we've also been thinking about how to analyse all of the data we're collecting about how people use our interventions. So we've got quite huge data sets that we don't quite know what to do with. And one thing we found useful was to look at that data visually, and it can help us to get at some of the answers and explore the data much more quickly than we can do just by looking at the numbers. And again, I'll give you some examples of the kinds of interventions we created and what this visual analysis looks like as I move through the slides. So just to recap on the advantages to using LifeGuide, it's fairly low cost. So if you're a junior researcher or a student, it gives you the opportunity to experiment with kind of digital health without needing large sums of money to do that. It's quite flexible, so it does support this iterative development cycle, so you have the control and you can make changes to the intervention based on feedback quite quickly. And it's very useful for collaboration, so we have a virtual research environment, and once you create an intervention you can share it with others, they can comment on it, you can help each other through the process. So just to briefly run through some example interventions. These are just interventions that have been created with LifeGuide many years ago and also recently, so you'll see some vast differences in what they look like, but that I don't have time to go through them all in detail, but a lot of these have the scope to provide tailored advice, so they're asking users questions and tailoring what can be given. They allow for user accounts, so people can log in, it can save their information and monitor that over time. And there's also scope if you want to kind of patient healthcare professional interaction, so the healthcare professional can log in, see the user's data and respond accordingly, so there is that functionality there, and that's just a whole bunch of interventions that have been created with the LifeGuide software. But I'm just going to focus on one example just to explain how it can be used iteratively and how you can use the software to recycle interventions and answer different research questions with them. So POWER is an online weight management intervention, and the idea is it supports a sustainable approach, so it's based on weight maintenance. And POWER itself has been used in several different projects, and it's seen several different iterations, which I'll talk you through. So in its initial development, it was designed to support weight management in primary care. So the idea was that it's a self-guided intervention that users then have nurse support alongside. And we ran a randomised controlled trial which looked at different types of nurse support. And the upshot of the trial was that it did support significant weight loss, and that actually remote support by email or telephone was better at maintaining support at 12 months compared to face-to-face support. But face-to-face support was a bit better at the 6 months, so in the short term. But all the details of the trial can be seen in the paper. Since then, we've adapted POWER for lots of different purposes. So we've conducted a community-based public health rollout where instead of nurse support, we're exploring the role of training up lay coaches to provide that support in the community. And we found that was also associated with weight loss, but it was only self-report in that particular study. We've also added to it in the form of an app. The idea behind that was that the app could help people to stick to their weight management goals in between when the online POWER sessions became available, which was on a weekly basis. And we conducted some in-depth case studies about how people got on with the app. And we found that it did increase their awareness of their physical activity and eating goals. So it seemed that the use of the app in conjunction with a website was a good way to keep people on track. And we've also conducted or adapted POWER for use without any additional support and rolled it out through workplaces in the northeast of the UK. And we've conducted, we're still analysing the data from that, but we've conducted some usage analysis using the visualisation tool, which I can show you briefly here. So the visualisation tools look like this. And the idea is that each row is a person and each burst of colour is a particular part of the website that we've coded up. And you can see on the left is those who just used the POWER website, so didn't choose to download the app or couldn't download the app. And on the right is those who downloaded the website and used the app. And we were just looking for different bursts of colour to see if there was any differences in the way the online website was used, depending on whether or not they downloaded the app. And what we found was that there were more bursts of orange in the app users graph. And what that means is that each time someone logs into POWER, they conduct a goal and weight review. After they've done that review, they've then got the option to look at more information on the website if they want to, or they could log out at that stage. So those who downloaded the app were much more likely to go on and look at that extra content. So that might suggest that having downloaded the app could encourage greater use of the information on the website. But what we also found was greater bursts of red in the app users graph, and that was meaning that problem-solving things were being triggered, which means that during the goal and weight review they'd reported struggling to achieve their goals. So that's kind of telling us that perhaps it's something about the person downloading the app rather than the app itself encouraging greater usage, and it might just be that those who are struggling a bit more need a bit more support and are taking advantage of all the support available. So the idea behind showing you this was a kind of more detailed analysis of the usage can give much better insights about what's going on with your results than just looking at the kind of surface values on their own, and might have led to quite a misleading conclusion about what benefit the app was providing. So in terms of future plans, Power's still going, and we've got a pilot study set up at the moment, and we've adapted Power for use with support from pharmacies, and we're going to disseminate through pharmacies and see if that's a kind of way to scale up Power and support that within the community. We're also looking at routes to support national dissemination of Power through local authorities and clinical missioning groups in the UK. So that's kind of all I think I have time to tell you, other than to say that if you want any more information about LifeGuide itself, you can visit our website. And we also have newsletters, so you can contact our administrator if you do want to be kept up to date with that. And we also periodically run workshops and training sessions that offer a bit more detail than I was able to provide today. And if you want any more information about anything that's coming up, or you want to host one yourself, again, you can contact our team. In terms of where we're going next, with LifeGuide and the person-based approach, we're continuing to develop new interventions to support unmet health needs. So we have various projects including screening and treating malnutrition in older adults, hypertension management, self-management in cancer and stroke survivors, asthma, distress, back pain, and various other conditions. And we also have projects in the pipeline to enhance LifeGuide and the capabilities of that further, and in particular we're interested in being able to integrate environmental and wearable sensors to support the development of just-in-time interventions, because we're aware that LifeGuide's not really kept pace with the rapid advancement of technology, so we're going to do some work to sort that out. I just wanted to end with acknowledging the core LifeGuide team at Southampton, so there's all their lovely faces. And we couldn't have done this work without the wider team at Southampton, a number of external collaborators. There were too many to list individually on the slide. I've just listed some of the institutions I've worked with, and also those who funded the project. And thank you to everyone for listening.